So now I want to tackle the question of, why is it so difficult? You know, the rules, the information that we're generating here, trials come from the academic community and, of course, industry. They're experts in the area that can focus on that. Maybe 100% of their time is focused on just breast cancer, just lung cancer. And by the way, that's full time. It's dramatically complex with all the things that I noted in the previous segment. But in fact, we know, estimated, that 85 to 90% of cancer patients in the United States are actually taken care of in the community. They're taken care of by community doctors, community oncologists, who may try to specialize to some extent, and maybe can in a very large practice. But the reality is, changes are happening so quickly. And if you're taking care of multiple diseases and the patients come into you and say, well, what about this? What about that? What is optimal therapy? And you go from one patient to the next, maybe a 15-minute visit, maybe a 20-minute visit, maybe a new lesion occurred, maybe a new abnormality that you detected on a liquid tumor biopsy, and you got 15 to 20 minutes to make decisions. How do you determine all that? So the focus I'm making is, the reality is today, it's one thing to say, well, the academic community can handle this. They can write the papers. They can get up on the podium. They can give CME programs. But what about the 90% of patients taken care of outside of that academic community? Where is the organized decision support for the community oncologists who are always and only trying to do their best for their patients in this increasingly complex arena? You mentioned pathways. Come on. Enough said on that. Pathways can provide some value. What? First and second line treatment? What about beyond that? What about cancer as a chronic illness? And often the pathways are things like, well, here's one option, here's a second option, here's a third option. How does that help you? Of course, you have dozens of insurers you deal with who will tell you what you can do or not do, which may not have anything to do with best evidence, but what they'll pay for. And your practice, you have to understand that as well. Show the complexities of the illness, the multiple diseases that most oncologists, certainly in the community, have to deal with. The fact that there isn't a real incentive for anyone to develop truly robust, I'm talking about a financial incentive for a company to come along and say, we are going to focus on pathways that are robust in a way that will help the community oncologists. Who's going to buy that? Who's going to pay for it? Who's going to update it, by the way, daily as new things come along? Those are questions that I would submit have not even begun to be addressed. I'm not even sure they've really adequately even been brought up. So I'm bringing them up. And in the next segment, I'm going to talk a little bit about the problem with the data that we, in fact, are supposed to be using to help determine optimal care today. I thank you for your attention.